Hey guys, it's Craig Bolger, one of the ultrasound faculty. Today we're going to be discussing how to scan the aorta and the IVC. As with any scan, we will cover the IA method. Why are we doing this scan? How are we going to get the pictures? What are we trying to find? And what are we going to do with it? For the aorta, the most common reason is a patient with uncontrolled hypertension who has back pain, chest pain, or belly pain, or in a patient with syncope of unclear etiology. First, we're going to pick our transducer. Both the curvilinear and phased array transducers make good choices for this exam, as they give you good depth and penetration as well as decent resolution. To perform this exam, ideally we want our patient lying supine. However, if they can't tolerate this secondary to pain, respiratory issues, or any other situation, the patient can be examined in the semi-recumbent or lateral decubitus position as well. First, we'll begin with our short axis. The leading edge will be placed towards the patient's right, and we'll start with the probe up in the epigastric region. Spanning through this area, we will interrogate the celiac trunk and SMA. Once we visualize these structures, we will sweep caudal with our probe towards the patient's umbilicus. This is commonly where the aorta will bifurcate. It's not uncommon when performing this sweep that you may come across bowel gas obstructing your view. Graded compression, meaning slight downward pressure, to displace this bowel gas may assist in obtaining these views. Next, we'll review some anatomy. First, we'll begin with the celiac trunk and its branches. So the celiac trunk comes off anterior to the abdominal aorta, which can be seen as an anechoic pulsatile circle sitting just atop the vertebral body. The vertebral body will have a hyperechoic periosteum and a dark shadow behind it. The IVC will be of varying shapes and sizes, but will be anechoic towards the patient's right. The common hepatic artery and splenic artery will be the two branches of the celiac trunk we can visualize at this level. In this view, the liver will be in our near field, providing an adequate window for us to see these structures. Next, we'll sweep down to the superior mesenteric artery. There's lots of anatomy at this level. The SMA will come off as a bullseye just anterior to the abdominal aorta. At this level, we'll be able to see potentially the left and right renal arteries branching off of the abdominal aorta. The vertebral body is Old Faithful in our far field as a landmark for the aorta and the IVC. And the IVC will be towards the patient's right. What we can see here is the left renal vein traveling between the SMA and aorta and dumping into the IVC. And the splenic vein going just anterior to the SMA, and it will dump into the portal confluence. Next, sweep down to the bifurcation. The right and left iliac arteries can be seen splitting off of the abdominal aorta at this level. Vertebral body will again be in our far field, and the IVC on screen left to the patient's right. Note that at this level, the vessels are much more superficial. As the aorta descends in the abdomen, it becomes more superficial. Next, we'll rotate our probe 90 degrees with the leading edge towards the patient's head. This will help us visualize the aorta in the long axis. Once we obtain a view of the aorta with the celiac trunk and SMA, we will slide the probe down to the umbilicus, interrogating the long axis aorta in its entirety. Let's review the anatomy. The SMA will branch off anterior and traverse caudal from the aorta. The celiac trunk will branch off anterior and travel cephalad into the liver. Again, the aorta will be the anechoic tube and the bifurcation you will see the right and left iliac arteries branching off. The spine can be seen as a mountain range appearance in the far field of this view. If our graded compression doesn't work and we can't displace the bowel gas, we can obtain a rescue view of the aorta. To do this, we place the probe in the anterior axillary line with the leading edge towards the patient's head. Keeping the probe perpendicular to the patient and parallel to the bed, we will sweep slightly posterior to find the liver in the near field with the IVC going through it and the aorta in the far field. The anatomy in this view can be a little bit confusing. Your far field is more medial and your near field more lateral, with your leading edge towards the patient's head and your receding edge towards the patient's feet. Let's review the anatomy. Your IVC is the anechoic structure within the liver, and your aorta is parallel and deep to this structure. Your liver will be in your near field. When measuring the aorta, it is extremely important to measure outer wall to outer wall. This will ensure you have an accurate diameter and are not missing any pathology. When measuring the aorta, it's really important to measure both short and long axis. In the short axis, we can occasionally be less than 90 degrees to the vessel, and thus getting an ope-like cut of it. This makes the user prone to overestimation of the aortic diameter. In long axis, we can be off the midline and measuring a much smaller diameter and underestimate the true diameter of the aorta. Let's look at some pathology. In this view, we can see an aortic aneurysm with a stent in place. Note the hyperechoic circle within the aorta that's being measured on screen left. If we took an inner to inner diameter, this aorta would appear normal, which it clearly isn't. On screen right, they are measuring outer wall to outer wall, showing the 4.2 centimeter AAA. It's important to measure the aorta in two views. However, sometimes finding those outer walls can be really challenging. In this long axis view of a AAA, note that not everything within the vessel is anechoic. It's not uncommon to see thrombus within the wall, which can make it much more challenging to truly find those outer walls. In this view, we see a fairly large AAA. I want you to note that the depth in this view is 21 centimeters, so habitus will not necessarily be a limitation to this exam. With the right amount of gel and carefully placed pressure, you can usually visualize the aorta, especially if it's pathologic. Here's what we're talking about before. Note that the aorta is very abnormal in this view. However, if one got confused and measured just the inner diameter, you would grossly underestimate the size of this pathologic aorta. There's a nice hypoechoic clot in the wall. Here we see an aortic dissection. For this pathology, ultrasound is very specific, meaning if we find it, we can feel pretty certain that it's there. However, it is not very sensitive, meaning we cannot rule it out if we don't see it. An aortic dissection will be noted by a hyperechoic flap within the lumen of the aorta and bidirectional blood flow around this flap. Let's talk medical decision making. Any aortic measurement less than 3 centimeters is considered normal. Diameters in the 3 to 5 centimeter range are considered aneurysmal. However, these usually only require medical management with antihypertensives. Anything over 5 centimeters diameter is aneurysmal and likely will require surgical repair. As mentioned before, ultrasound is specific for aortic dissection, but not sensitive. So if you have a high clinical suspicion for this diagnosis and aren't seeing it on ultrasound, additional testing, such as a CTA, should be ordered to truly rule this out. Now let's move on to the IVC. Our typical indications for this are undifferentiated hypotension and assessment of volume responsiveness. The structures we will be looking at are the inferior vena cava, the hepatic veins, the liver, the diaphragm, and the right atrium. To begin, we start with the leading edge towards the patient's head, nestled in epigastrium. I like to teach this as find the aorta first, and then sweep towards the patient's right or your left. The next anechoic tube you'll come across will be the IVC. As you can see, the IVC with the hepatic veins draining in, and it crosses over the diaphragm into the right atrium. How to measure the IVC. This is definitely something that will change over your 4 years in medical school. Previously, we used to teach that you will measure the IVC with M mode, 2 centimeters from the diaphragm. It is still important to measure the IVC at least 2 centimeters from the diaphragm, as it is often tethered prior to this point. However, the current school of thought is that cable index is likely the most accurate measurement. To assess cable index, save a video of the IVC and measure its max diameter and min diameter at a specific point. You take the maximum diameter minus the minimum diameter over the maximum diameter to calculate the cable index. What many of us use clinically is Gestalt. A plethoric IVC with minimal respiratory variation likely indicates that the patient will not be volume responsive and/or they have an obstructive pathology, versus an IVC with significant respiratory variation indicates that this patient will likely be fluid responsive. All of this requires clinical correlation, however. Let's look at this IVC. You can note that the walls are nearly touching with normal respiratory variation. If this patient is hypotensive, they will likely be fluid responsive. This IVC, however, has a very large diameter, 2.71 centimeters, and if visualized with normal respiratory physicity, would essentially have none. So let's compare these tracings. The top left shows a plethoric IVC with little to no respiratory variation. The top right shows an IVC with normal respiratory variation, some but not complete collapse. Both of the bottom images show IVCs with complete collapse with normal respiratory variation. If these patients were hypotensive, they would be volume responsive. One other pathology we may be able to visualize is a thrombus within the IVC. As you can see here, we have what should be an anechoic tube, however, it appears that there is something within it. This is a thrombus. You can note a little bit of anechoic region around it. If we were to place color, those regions would have flow versus the thrombosed area would not. With the IVC, you want to correlate to clinical status and vital signs. Previously, we used to correlate our IVC with central venous pressures. However, that is falling out of practice. If you have an IVC with greater than 50% collapse in a hypotensive patient, that patient is likely to be volume responsive. If you have an IVC with little to no respiratory variation that appears full, that patient is less likely to be volume responsive. However, keep in mind the caveat, clinical correlation required.